Chairwoman Capps, Ranking Member Shimkus, and members of the subcommittee, thank you for the invitation to discuss the CMS Incentive Program for Electronic Health Records, which is part of the American Recovery and Reinvestment Act of 2009. Certified EHR technology used in a meaningful way is one piece of a broader health information technology infrastructure needed to reform our nation's healthcare system and improve the quality and safety of care for both Medicare and Medicaid beneficiaries. On January 13, 2010, we published a proposed regulation that defined a meaningful use and described the eligibility and payment methodologies for the EHR incentive program. This NPRM was developed through close cooperation between CMS and the Office of the National Coordinator, and also allowed for extensive stakeholder input and recommendations from several federal advisory committees, in particular the HIT Policy Committee. The NPRM laid out 3 stages of meaningful use, with Stage 1 covering the first 2 years of the program. We received more than 2,000 comments on the proposed rule from interested stakeholders, including healthcare providers, associations, and patients. Most of the commenters felt that the proposed set of objectives was too difficult for Stage 1 and asked for some flexibility in meeting them. The agency carefully reviewed and considered all submitted comments and took them into account in making policy decisions for the final rule. Our goal was to be as inclusive and flexible as possible within the bounds of the statute. We continued to work closely with ONC and received additional recommendations from the HIT Policy Committee. It is important to note that this program provides payment incentives for both Medicaid and Medicare. The programs have different statutory requirements, but we tried to harmonize the meaningful use requirements as closely as possible for Stage 1. Both the CMS rule and the ONC Certification and Standard Rule, which sets out the functionality requirements for EHR, were displayed in the Federal Register on July 13, 2010, and will be published in the Federal Register tomorrow, July 28, 2010. I will now discuss some of the key areas of the final rule. Eligible professionals, the major change in that was to expand the definition of eligibility to hospital-based physicians who work primarily in outpatient departments. This was made possible by a change to the original statutory language made in the Continuing Education Extension Act of 2010. Most Medicare Advantage affiliated eligible professionals will also qualify for this incentive if they are able to show meaningful use. And on the Medicaid side, we provide additional flexibility for determining patient volume in order to qualify more EPs. Eligible hospitals, we've received, as was noted by a number of the committee members, much comment and requests that CMS recognize each campus of a multi-campus hospital for the incentive payments. We understand that this issue is of importance to members of Congress, the hospitals, and the public. However, from the agency's perspective, we believe it's important to treat hospitals consistently, and the decision to deviate from long-standing hospital policy in this particular instance without clear statutory direction to do so would have made CMS vulnerable to legal challenges asserting our policies are being implemented in an arbitrary manner. We intend to remain consistent with other payment policies and make incentive payments based upon how hospitals have organized themselves under provider numbers. There's a more detailed discussion of this issue in my written testimony, and I'm happy to respond to questions on this. We'll continue to work with all interested stakeholders in future rulemaking related to the implementation. The other major hospital issues was with the Medicaid program, and in response to public comments on the proposed rule, we added critical access hospitals to the definition of a Medicaid acute hospital in order to allow CAHs to qualify for both programs. The major changes we made in the rule were with the meaningful use definitions. As we mentioned in the NPRM, we received a number of comments that asked for more flexibility, and we decided to make some changes based on these comments that I'll address in the next few moments. Some of the major changes were modifying the R-nothing approach to objectives that must be met for meaningful use, and reducing this requirement to a required set or core and a menu set or optional set. Eligible hospitals and professionals will have the flexibility to defer up to 5 of the menu set objectives. Where appropriate, thresholds to meet meaningful use requirements were reduced in the final rule in response to comments. We also removed the administrative transaction requirements in the final rule in response to comments that these transactions are often done through practice management software as opposed to EHRs. We also modified the state's ability to impose more robust requirements that would have made it more difficult for Medicaid providers to achieve elevated targets. We believe it is important for states to have some flexibility, so we preserved the flexibility. However, in response to the concerns raised, it was limited to 4 public health measures. We also added additional objectives for patient-specific education resources, and advanced directives for hospitals were added in response to numerous requests in the comments and the HIT Policy Committee recommendations. It is important to note that Medicaid providers are not required to meet meaningful use criteria in their first participating year. Instead, they may qualify for an incentive payment if they adopt, implement, or upgrade certified EHR technology. In subsequent years, Medicaid providers must demonstrate meaningful use in order to receive the EHR incentive payments. The meaningful use definition described for Medicare will also be the minimum requirement for the Medicaid EHR incentive program. Unlike the Medicare program, however, there are no Medicaid penalties for EPs and hospitals that will be unable to demonstrate meaningful use. Finally, I want to mention that Congress recognized the critical importance of reporting quality measures through EHRs in the high-tech legislation. We support this requirement, but recognize that the infrastructure to support the reporting of quality measures through EHRs is not yet available. In response to comments, CMS limited CQMs to only those which have electronic specifications. Eligible providers will now be required to report on 3 core measures and another from a set of 41 measures. Hospitals will be required to report on 15 measures as applicable to their population. In conclusion, the CMS and ONC final rules lay the groundwork for establishing a robust national healthcare infrastructure that supports the adoption of EHR technology that can help providers practice safer and more effective medicine. CMS understands the scope of these programs is vast, and that doctors and facilities across the country have varying awareness of EHRs and of the program. We are working closely with ONC to conduct wide-scale outreach to educate those eligible for the program, as well as working with the states and provider stakeholders. We look forward to working with Congress and our many stakeholder partners as we implement this rule and future rules and advance the use of HIT in our healthcare system. Thank you very much for allowing me to